Hey everyone, my name is Eric Norman, and welcome to the Mettle podcast. I am a physical therapist, and soon we will be joined by my good friend Christian Jorns, who is also a physical therapist. And today we're going to be discussing this idea of tendinopathy around the shoulder joint. We're going to discuss an article. Article title is Exercise for Rotator Cuff Tendinopathy, Proposed Mechanisms of Recovery. I know that sounds like a lot. And today we're going to try and break it down into a little bit more of basic terms that hopefully we can all understand and take away some good practical advice for those who might be having shoulder pain, or hopefully if you know someone who's having shoulder pain, you can lead them in the right direction. As always, if you have any questions or want to get started on a training program, please feel free to reach out to one of us or check us out on social media, Instagram or Facebook at Mettle, or send us an email you can find on our pages as well. So thanks everyone for listening. Hope you have a great day and enjoy the podcast. Hey Christian, how's it going, man?
Hey, things are really good. Just glad I get to take a break from helping my wife prepare for her soup party tonight. We have like a dozen people coming over.
Nice.
So I'm just like basically the butler, doing all the cleaning, getting stuff prepped. So after this, I'm getting right back to that.
There you go.
What are you up to?
I'm just I did a little bit of house cleaning today, just very just boring stuff. I'm gonna do some yard work later.
Of course you are.
Super.
Patch up that grass.
Dude, you gotta get it ready for the winter's coming. It's on its way. You gotta get it ready and prep.
Are you gonna dethatch?
I might. I've been thinking probably later in October. And probably just like my backyard. Because to be honest with you, I don't really care much about the front yard, which is weird to say, but spend most of the time in the backyard.
That's so weird to say.
I know. Spend most of the time in the backyard, so it's like I want to get that looking really nice. But
the only two lawn words I know are dethatch and top dress. And
top dress.
Top dress, yeah. So I do both of those sometimes in the backyard just because like I make my own compost, and so
nice.
I got to get rid of it. So I just I'll dethatch and throw a bunch of compost on top of the grass in the backyard, and that's called top dressing. In case you didn't know.
There you go. Love it. Learn something new. But yeah, I was gonna ask, are you wearing like an apron or something? Are you going full out with this?
Got my tux at the dry cleaners right now. I'm about to go pick that up. No.
There you go. Nice.
I haven't planned the outfit yet, but I'm sure it's going to be exactly what I have on right now.
There you go. Yeah. Oh yeah. Next thing I was going to ask you was, how are things going over in your neck of the woods with the training stuff? I know last time we talked about you getting into more Olympic lifting. Have you've been working on that a little bit?
Yeah, I have been. It's actually been a lot of fun. It's just nice to not feel as much, I don't know, like demotivation to train. I'm excited to go into my garage and do these movements. So that's been a lot of fun. And I feel like the technique has really come back much quicker than I thought it would, because I trained these movements exclusively for 2 years, several years ago, but I haven't touched them since. And so it just took a couple sessions for them to really come back. And now that I'm older and wiser, and I've been much more into motor learning and like how to be a better coach with the things we say and even don't say, I've been thinking about external cues in the context of the snatch and clean and jerk. And so like, if anyone's familiar with coaching these movements, they've probably heard things like, oh, you gotta like shrug the bar, or like do all these really silly things with how you think about your body. But it's a lot of steps to be thinking about, which really doesn't help the way you do these movements. So a simple cue that I've been giving myself for the clean, for example, is I just want to catch the bar on the top of my shoulders in the same spot every time. And so I don't think about anything else between the pull and the catch. I just aim to catch it right where it needs to be. And for like the split jerk, for example, I'm not thinking about like a dip and drive or whatever else. I'm just thinking about, I want to get my feet to land in that split position in certain spots in my platform. I actually think about my shoes, not my feet. And I just try to make the shoes hit the same spot on the platform every single time. And that way I know that I'm in the correct like depth of that split jerk, and the bar is just going to take care of the rest.
Nice. Love it.
Yeah. It actually reminds me of a patient I have right now. He's a state champ pole vaulter, And I asked him, I was like, so like, what do you think about when you're pole vaulting? I know it's like super technical. He's like, honestly, I black out. I don't think about anything because there are like a dozen or so steps that you learn when you're beginning. And he's like, I don't think about any of those. It's just all of a sudden on the ground. The next thing I know, I'm on my back. Like that's just how it
Yeah.
works.
Yeah. Yeah. That's wild, man. A lot of that you brought up kind of like just like the motor learning, but just that processing that's going on behind the scenes, just repetition after repetition for them. And, you know, at some point it's just like that second nature. But dude, I'm glad that you brought that up because I think that's a very simple or more simple way of looking at something like external cues. And I was going to add on to that. You've motivated me to do a little bit of some Olympic lifting. So yesterday I was repping out some hang cleans and some kettlebell snatches. And so that was good. That was good. I haven't felt that type of like a workout in a while where like you do a set and then like you can feel that heart racing. I mean, it's worked to squat heavy and whatnot as well, but like it feels different if you're doing like hang cleans versus like a back squat.
Totally. Like that's one of the first things I noticed was like doing a clean and jerk double.
Yeah.
I was like breathing very heavily afterwards. It
Yeah.
took me by surprise. I forgot how hard your body has to work to do those.
Absolutely. Nope. Love it. Love it, man.
Yeah, how's your training?
Yeah. Yeah, it's going all right. Like I said, I started dabbling a little bit into some of those more Olympic lift movements over the last couple of days or this week really since we spoke last. But then one of the things I've been trying to do lately is as I'm progressing my weights under like the barbell with back squat, deadlift, bench, etc. I've been trying to add in like 1 or 2 days of doing some cardio. I recently did a running eval on an individual in the clinic, and she is very efficient with her running, much more efficient than I am, and used the example of how the economy of running and this idea of if you run 5K and I run a 5K, my caloric expenditure is going to be much greater because I suck at running. My body has to use much more effort to get me across the finish line. So I've been learning my efficiency when I'm doing running is pretty terrible, but that's all right. I'm burning calories, right? Is that all that matters? Is just you're burning calories?
Gotta burn off those bush lights somehow.
Yeah. Yeah. Bush lights, Coors lights, McGoldens, all the light beer.
You don't discriminate.
No, no, I'm with it. So let's get into the article for the day. I'll do a quick little introduction for individuals who may not be aware of some of these terms that we're going to be talking about, and then I'll hand it off to Christian to further some other points. But the article for today that we're going to break down and discuss and hopefully make it very kind of user friendly so that we can all have a good grasp on it is the name of the article is Exercise for Rotator Cuff Tendinopathy. And then the second bit is Proposed Mechanisms of Recovery. We'll get into that part a little bit later, but I want to focus on the first part of that. Exercise, we all know what that term kind of implies. For rotator cuff tendinopathy, I'm sure everyone listening to this has heard of the rotator cuff, have an idea of what it is. Rotator cuff is 4 muscles in the shoulder. You got kind of one more in like the front side of that shoulder blade, one on top, and then 2 in the back. And what they do is they provide some rotation within that shoulder joint. But another big part of what they do is they're kind of thought of as these dynamic stabilizers. For those of you who don't know, your shoulder joint is kind of a shallow joint, and it's meant to be that way, so it has a lot of mobility. But in order for it not to become unstable, we have different things in place, one of them being the rotator cuff. So when you bring your arm overhead, right, the rotator cuff helps bring the arm in the socket stays center and moves nicely. All right. So that's a quick description of what the rotator cuff is. Yes, it rotates and moves the arm, but it also helps to stabilize that arm within the joint. And then the second part of that is tendinopathy. So tendinopathy is just real quick, Christian. I know that you've visited this website before, I look at it from time to time, but people who might want just a quick glimpse of information on something, Physiopedia is a online resource for physical therapists and individuals wanting to learn more about like a diagnosis. They describe tendinopathies as a generic descriptor of clinical conditions, both pain and pathological characteristics of tendons that have failed the healing response. So basically what we're seeing here is that tendinopathies is this, this repetitive loading and thought to be maybe some tendon degeneration that have failed the healing response. And now we're getting kind of this newer environment within that tendon that can provoke pain or discomfort.
Yeah, okay. I think that's a great introduction to just like what these terms mean. And yeah, with tendinopathy, you may not have pain, right? Like it's just a change in the way the fibers look and some of the other stuff that's around them, like the immune cells and the water content and all that different stuff. And oftentimes, though, those changes are associated with pain, but thankfully, we can do certain things like strength training to make that a bit better. I do think it'd be helpful to go through just like what tendons are, what they do, what they're like, because the next section in this article is all about tendon structure anyways.
Yeah.
And so what I often say to patients is that tendons work like bungee cords, but they look more like a rope. And so for the bungee cord bit, thicker bungee cords are harder to stretch, but they also then recoil with more force. And then thinner ones do the exact opposite. And then tendons are almost exactly the same as that, where thicker tendons like the Achilles store a lot more energy than smaller ones like the ones in the back of your hand. So the size of that bungee cord, that tendon does matter, but it's not the entire equation when it comes to tendons. For them, we can also make the material properties of a tendon work better through strength training itself. And in tendinopathy, those fibers or those materials that make up your tendon are often weaker and disorganized. So that brings us to like the whole rope part, where I want you to picture frayed rope compared to a brand new rope. Ideally, you want your tendons to look like a new rope without any frays at all. Strength training will make those tendons a little thicker and more organized, much like a new rope. And to keep this a little simple, it just makes the fibers within your tendon work better. You can compare that to having like a crappy cotton rope versus a high-grade climbing rope with very fancy fibers in there. That strength training itself will make those fibers themselves just become higher quality over time. It makes them more robust and better able to store energy. One thing that I actually thought was pretty cool from the tendon structure bit was that the tendons have this short-term thickening phase. I don't know if you read that in it, where the tendons will get thicker when you do things like normal everyday chores or like with pitchers. Or they even did some studies where they had folks do some rotator cuff based exercises and then measured the thickness of the tendon before, but then also after. And those tendons show some of that short-term thickening, kind of like how muscles get pumped.
Yeah. No, I was thinking the same thing. I remember reading that, and it's really interesting. I think it shows that, and again, this might be a little bit of a leap, but I think it's just an interesting point that in order to, create change in the body, we don't necessarily need to be doing 3 sets of 8 reps at, 75 to 80%, 1 rep max or something. Like we don't have to be going pretty extreme with our programming. It can just be as simple as, individuals like it's spring cleaning day and we're doing windows and we're going to see some change. We're going to see some change in those tendon structures. I think sometimes that can get lost. Now, I'm not trying to say that spring cleaning is a good enough substitute for strength training. I just think it's sometimes we just think a lot about how like, oh, I just did these different chores today. It's like, well, the body responds to stress if it's, very minimal stress or very significant stress, like in strength.
Absolutely. And that kind of leads me to the whole, like going back to the how exercise or movement in general causes that pump in the tendons.
Mm-hmm.
In the short term, that's generally a good thing. That pump where you have like more really good healing substances entering the tendon, that's how your tendon is going to adapt and get stronger, become more resilient over time. The problem though is, to use your example, if you're using your shoulder day in, day out, cleaning windows the exact same way, and that tendon never gets a chance to recover from that pump, and it doesn't get a chance to fully recover. It's that repetitive cycle over and over and over again of you not giving it a chance to fully recover that leads to tendinopathy. It's that accumulation of what the article says, like micro trauma or micro tears. That stuff eventually just reaches a critical mass where you often will then begin to have symptoms. And so that pump, that use from exercise or cleaning windows is really good. You want that, but you also need it to clear up. And I think that's just like a super important framework to have for anyone to just conceptualize how to reduce that long-term injury risk. But I get that that's a really tough thing to tell people who maybe they have to do the same task every single day in the same way at their job. And that is one of the hardest parts about our job, is helping those kinds of people.
Yeah. Especially if it's something like in their dominant hand or something, and it's like you're asking me to use my non-dominant hand, like that's going to be very inefficient when I'm trying to be efficient at my job. So yeah, it's very much a give and take with that type of stuff, especially when we're discussing things like activity modification with individuals. And you kind of have to weigh out the pros and cons. You have to weigh out the benefits of, if we do this, what might suffer a little bit, and is that going to be okay or enough benefit in the short term to, try and recover from something like this tendinopathy. But yeah, the other thing I wanted to bring up from earlier in the article, which I think was technically still in the introduction, but before we move on to the next section, I just wanted to bring up too about how, in the intro they discussed that the recovery from a rotator cuff tendinopathy can be limited. 40 to 50% of patients developing recurrent chronic symptoms. I just thought that was an interesting stat. And, if you've listened to our other podcasts, we bring up some of these statistics and we talk about it, especially within like low back pain, or things like surrounding the ACL and ACL recovery. But, just for another, big hitter here, it's like, unfortunately, we might not see 100% of individuals recovering from this type of rotator cuff tendinopathy. And I think that speaks to the complexity at which we're going to get into here in a little bit of just what exactly surrounds these types of just tendinopathies, or more specifically the rotator.
Yeah, and I think that's a good segue into the overall thesis of this research article, which is the authors proposed thinking about rotator cuff tendinopathy mechanisms through 4 different lenses. One that we already talked about a bit was the tendon structure itself. When you have folks that have this kind of issue and they're in pain, it can be helpful to think about the tendon structure itself and then applying interventions like exercise with the structure in mind and how to make that better. There's also neuromuscular factors that we'll talk about in a bit. And then pain and sensory motor processing. So just like how your body perceives pain, how it coordinates those movements. And then the last domain they mention is psychosocial. And we talked about this on other podcasts, especially in the low back, where this really comes up in the research, is that your emotional state and the things that you're going through in life really play a legitimate and can play a major role in your pain experience with rotator cuff tendinopathy, not just low back pain.
Yeah, absolutely. Yep, absolutely. So I think it'd be good to get into the next part of the research article, which is talking about that neuromuscular deficits and how they describe that. And so one of the things that I thought was kind of interesting is they give this table within the article, and it talks about how the effects of exercise, and it basically just gives like an arrow up or down, right? And kind of what exercise can do in those different movements. So just to give people an idea or a sense of what the hell is neuromuscular factors and what's going on here. What do you mean by that? When they talk about neuromuscular factors, they're talking about different mechanisms that are helping coordinate or move that environment around the shoulder for a successful movement. So one of them being, rotator cuff muscle onset time. So like I mentioned earlier in the podcast, how rotator cuffs have this job to have dynamic stabilization of that arm in the socket. If we have a tendinopathy, we might not have appropriate, onset time of that rotator cuff, which can lead to just more possible pain, discomfort, or just overall reduced function. And we're seeing from this article that we can have reduced onset time, which means that rotator cuff is coming on a quicker pace, which then hopefully could keep the kinematics to that shoulder joint movement more appropriate, reducing pain or improving function. So I thought that was a really interesting one. And obviously there's a table that goes through a bunch of other ones. And I don't know if you want to discuss those, Christian, or how you want to go about that. But I just thought that it's just a really interesting point to think about, how it's not just the strength of the tendon or the change of the tendon, but it's also how the tendon or the muscles function in that area.
Yeah, and that certainly can be a factor in someone's pain. The authors of the article go on to acknowledge that the research around those firing patterns and that coordination and all that is mixed in how impactful those changes are. And so like a real world example of this is going to be, people that have been to PT or seen coaching videos online or whatever have probably heard all sorts of things like, you gotta like retract your scapula, you gotta pull those shoulder blades back, you gotta keep your shoulder blades down when you lift your arm overhead. All these different things, those are neuromuscular factors and how you coordinate those movements.
Mm-hmm.
Changing those things over time has become less correlated with your symptoms. Like we used to think it was more important. Now we think it's not as important for helping folks get out of this pain. And I think of this as like a chicken and the egg sort of thing. So, and the authors go into this too, which is, did the way that you move your shoulder, like let's say you go to lift your arm and you shrug your shoulder towards your ear way too much compared to your other side, or compared to like what other people might do. So did the way you move that arm cause the issue, or did the pain you just developed in that shoulder cause you to move your shoulder differently? And so I think of that as it's like a limp. It's like a limp, but it's in your arm. So did you decide to start limping out of nowhere and now you have pain because of it? Or are you limping because something happened, because you rolled your ankle? So it really begs the question of, do those firing patterns and timing of your shoulder and shoulder blade muscles really matter? And if they do, to what extent? All that stuff is still up for debate. Overall, I would say that it's more of a minor concern compared to other things like strength training to improve the tendon structure. At least that's what the research seems to show.
Mm-hmm.
But I don't want people to think that like you should never coach movement. You should never be concerned about neuromuscular patterns. Like we've said before, if someone has pain in an area and they seem to move that area a little bit weirdly compared to the average person we see that's pain-free, or compared to their other side, and if you go and try to give them some tips on how to change that movement and it makes them feel a bit better, totally, that's useful, that's relevant, and I do encourage making some of those changes.
Yeah, absolutely. Yeah, and I think that's I'm glad you cleared that up, or kind of brought more of the what they discuss in the article into that, to give a little bit more light kind of around that topic. Because I would say neuromuscular, like re-education, if that's what we want to call it, for lack of a better term. I feel like that's what we see a lot on things like social media and whatnot, kind of things you were describing, right? The scapular retraction, or like scapular winging, or these different, what we think of as kind of like faulty movement patterns, and I use quotations with that. And I think it's good for listeners and people out there to know that the research, like you said, is mixed on that. And we're not, it's probably more of a smaller detail to discuss that, but versus it being this, big kind of, if you fix your scapular winging or if you fix your lack of rotation, you're going to not have shoulder pain anymore. I mean, I would beg to differ that the research says that's probably not quite the case.
Yeah, I'm glad you brought up the whole social media thing, because the surest way to tell someone doesn't know what they're talking about is if they say that there's a single way that you have to move. Or they throw out a ton of jargon, and it's like all around these different neuromuscular factors, whether that's going to be your back, about like, oh, you got to brace, you got to keep your spine super stable, or it's like your knee, where your knee can never go inwards ever, or your shoulder, where like you should never shrug your shoulder when you go overhead. All those things, like if people are really adamant about that stuff, I just know immediately they have no idea what they're talking about, or like they've read a single article probably from some blog, or like watched someone else's content and just like stole that one thing, and they think it's just like the best thing in the world and they're going to help everyone. And I'm sure they have great intentions, but that's just like not how it works in the real world.
Right. Yeah, absolutely. I couldn't agree more. Everything you said, I would just resonate that. It's usually a little bit more, the human body is a little bit more in depth than what you can put into like a 3-minute video online. Hence why, our podcast, we're approaching 30 minutes and we still got more stuff to talk about. Let's keep going forward from there. Anything else, Christian, on neuromuscular factors, kinematics, things of that nature that you wanted to discuss before we moved on to the next section?
The one thing I'd say is there's a section on force, and here's a quote from the section, which is, "There is not clear evidence that force deficits are consistently present in rotator cuff tendinopathy." What that means is that you don't have to get stronger to feel better. Or someone that has pain in the rotator cuff or has tendinopathy, they may not actually be weaker. They might be stronger than their other side. It just now hurts. So that begs the question of like, okay, why are we doing strengthening? Like, what's the point of it? Maybe I'm already strong enough to do what I want to do. This is where I'll say to patients that we do strengthening for 2 reasons. One, you may hurt. You may hurt in your shoulder because what you're doing is more than you can handle right now. And getting you stronger will move that capacity or move that tolerance a bit farther so that you can do more stuff before you have pain. And 2, even if that's not the issue, even if you are strong enough to do what you want to do, but you still hurt, sometimes we just need to teach your body that these movements that you're doing aren't scary, aren't painful, aren't harmful, and we just got to get your body used to doing them again comfortably, which I think is a nice segue into the third domain or like mechanism of rotator cuff tendinopathy.
Absolutely. Yeah. Nicely done. Nicely done. Way to recap that and segue us into that. That's good. That's good. I got to start taking lessons from you, I think. All right. So the next one we're going to talk about, pain and sensory motor processing. So this could have a whole podcast, and a whole series of podcasts, or we can just, refer people to, other individuals in the field. For example, Greg Lehman. He discusses this stuff very simple, and it's very effective when it comes to pain and pain processing and kind of what that is. We'll do our best here in the next couple of minutes just to break down how this can affect the tendon area. So one of the big themes that I think that they discuss in the article, and what, we see throughout the whole body, but today specifically in tendinopathy, is this idea of central sensitization and kind of how that can play a role in how we experience pain. And so just real quick, kind of what is central sensitization? It is a way of our body processes, or our nervous system processes pain and discomfort. In the article, it discusses that it is, quote, an increased responsiveness. All right, so we're getting more kind of signals sent, if we want to think about it that way, of what's called our nociceptive neurons. that's just a fancy way of saying nerves in the body that carry pain from point A up to point B, right? Wherever you want to think about it, basically from the outside to the inside. So we see that for some reason, we have this uptick in response to different stimulus throughout the body that for individual A, they might think, yeah, it's a little bit of soreness, but goes away and I'm fine. For individual B, that same stimulus, that might put them out for a couple hours in terms of that just really flared up my shoulder pain. So that's kind of this idea of very basic kind of central sensitization and how patients can really feel a difference from like, I lift 5 pounds, I get no pain. I lift 5 pounds and like that stuff, sets me off for the rest of the day.
Yeah. And I thought that was a pretty good thing that they brought up in the article, where I think a lot of us, I'm guilty of this, don't really think about pain processing or like psychosocial factors, which we'll get into in a bit,
Mm-hmm.
as being a major player in shoulder pain. I guess that's just like my ignorance or bias, but it's nice that they brought that up, in that some people have shoulder pain just because their nervous system is on high alert. Like you said, central sensitization, things are on high alert. And we got to make sure that we're paying attention to that. And a practical example of that would be someone has a lot of fear or a lot of pain with certain movements, and you get the sense that the more that you try to work through that pain and get them a bit stronger, like you might for a classic just pure mechanical tendon issue, they get a lot worse. They start getting more flared up, more worried. They want to move less, do fewer things. That's the kind of person where maybe you just need to meet them where they're at, expose them to movements and loads that are really comfortable, that don't make them worried. And maybe it's going to be doing the thing that generally hurts at an easier level, or maybe it's something different entirely, because right now that one movement in particular is just not going to happen, no matter how you try to make it easier. And then you can come back and revisit that later. Are you truly getting their tendon stronger in that circumstance? Probably not so much. At least way less so than a dedicated plan of like heavy loading over long or several months. But you're just teaching their body that those movements are okay to do again. You're bringing down that high alert in their nerves and in their brain to where it's just getting more normalized. And you do that by meeting them where they're at and not pushing through a whole bunch. And
Mm-hmm.
there are experts that do this far better than we do. You have pain physicians that can do a bit of this stuff. You've got psychologists and counselors that specialize in having these conversations around pain. And we'll often refer to those people if we feel like it's just a tough case and we're not prepared to do it well.
Yep. Yeah, absolutely. And just the last point I'll make about that, because like you said, when we're doing these, if we're taking this approach or this perspective on rotator cuff tendinopathy, which is this individual we're suspecting having some central sensitization to, or this higher pain response, the things that we're doing probably aren't, creating or influencing this big change in their strength of the tendon or within the muscle, etc. But for majority of people, at the end of the day, what we really care about is like, do I have pain or not? Right? I think that's just a very simple question that can get lost when we're doing rehab or when an individual is, at the doctor's office. At the end of the day, it's, I have pain and I want the pain to go away. And then once the pain is gone, then we can start talking about it. Maybe, hey, let's get you on a program to try and improve your resiliency. I like how you mentioned, building, more strength so that it can take on more stress. Again, plugging Greg Lehman, he talks about that in like his cup analogy, right? You can either reduce the water in the cup or you can build a bigger cup. And so I think that's a really great way of looking at something like this, is we're trying to influence individuals to build this bigger cup so that they can be more resilient or take on more of the stress of life and physical stress to that area. And then just lastly, I think this ties in pretty well with the fourth mechanism that we wanted to talk about today. and that's psychosocial factors. In the article, they lay out different psychological factors that could include depression, anxiety, sleep disturbance, pain catastrophizing, kinesiophobia, which that is the kind of fear of certain movements, having low self-efficacy or expectations of recovery, and resilience. Those things definitely play a role. And I'm with you, Christian. Sometimes I don't give the devil its due when it comes to some of those things, I think. And I'll admit I could probably be better at, identifying those things and trying to target those more, especially if more of a, traditional physical therapy plan of care isn't quite working when it comes to therapeutic exercise. Absolutely, I think that those factors can play a role into how an individual is recovering or, progressing throughout their rehab.
Yeah, and these psychosocial factors you mentioned, like you said, it's up for debate on how much they actually matter in various different patients, different parts of your body. But the general consensus is that they do really seem to matter, especially in low back pain and neck pain, but also in shoulder pain. And when you want to help people that have these sorts of things going on, one of the worst things you can do as a therapist, and like what I think the patient just doesn't really care about, is like saying stuff like, just so you know, pain catastrophizing is correlated with poor outcomes. Like that's it just means nothing. That statement just means nothing to the patient. And so early on in my career, like when that's like really all I knew how to say, yes, I said those kinds of things, and I feel dumb for saying them now, but we all get better over time.
Yeah.
And now
Guilty.
What I try to do is I try to incorporate those lessons into everything I do. From the minute I meet the patient, every word that comes out of my mouth, those types of things are present in what I say. And so like an example I'll give you is it could be something as simple as, hey, I know this thing hurts, but I just want you to know that you're not doing any serious damage to your shoulder when you do X, Y, or Z movement. It's okay to do it if you have to do it. You're going to be fine. Just giving them that permission and that reassurance that, all right, I know that this thing hurts, but I know I'm good. Nothing's going to go crazy wrong here. Yes, I might have more pain, but that pain does not mean that I'm harming myself. Or it'll be something like, hey, I know your doctor found this small rotator cuff tear on your MRI, and I totally understand that you're worried about that, but I just want you to know that it's not something you really need to be afraid of. We see these all the time. People have these things without even knowing it. And honestly, we can get you a lot better just by getting your shoulder more conditioned, giving you a bigger cup, as you said.
Mm-hmm.
And I bet you won't even notice that rotator cuff tear anymore over time. And that kind of brings me back to the comment I made earlier about like the bungee cord and the rope, where people often think that their tendons are just this inert structure. Like it's just like a rope, and once it begins to fray or tear, oh, you're done. It's over. It's a lost cause. While you may not be able to repair all those different like frays in that rope when it comes to your tendon, unlike a rope, what you can do with a tendon is you can make the remaining fibers that you have way stronger. So it doesn't even matter that some of that's frayed. The remaining stuff is so robust that it can handle whatever you want to do without even noticing it. And I think having those kinds of messages for patients and saying them confidently and being consistent in your language, and then of course proving to them over time that it actually does work, that's a super powerful thing. We have to make sure that we're all communicating with our patients, at least in some way, to articulate those psychosocial concepts to them.
Yeah, absolutely. Couldn't agree more. And just kind of hop on the back of what you just said there. I guess you could call this a closing statement or kind of a conclusion from what we've been discussing today. One of the things that I'll tell patients is, if they come in to an eval and they say like, oh, I've been told to do these exercises or stretches I found on YouTube for my shoulder pain, and it's just making things worse, right? And it's like, if you're going to give me exercises, how is that going to help? I'm already doing exercises and it's making things worse. I totally see where they're coming from. Absolutely. And one of the things that I'll tell them is I'll say, look, there's no bad exercise, right? Active range of motion against gravity, versus, pressing overhead a dumbbell 55 pounds. Two very different exercises, but I would argue that neither of them are inherently bad. It's just that sometimes we can have poorly prescribed exercises with missing the reason as to why we're doing it, right? And that's what we see a lot of times when we have individuals going on Instagram, going on YouTube, going on Google and reading these different articles or watching these videos, and they take these exercises, and those exercises aren't bad. They're good exercises, but without truly knowing what exactly is going on in, let's say, for this example, the shoulder, we can often miss or poorly prescribe that exercise in terms of sets, reps, intensities, rest break frequency throughout the week, just kind of the overall volume of what we're doing. And we can also miss the why, like we saw in this article. The why can be strength. Maybe you want to target, neuromuscular factors. We can target the psychosocial factors. We can also target more of the, why am I losing my train of thought now? The pain and sensory motor processing. That's what I was trying to say. So we have different whys behind we prescribe exercise and how we prescribe it. And so again, there's no bad exercise. It's just that sometimes we can just have poor prescription of that exercise, or we're missing the why when it comes to these different factors.
To steal a line from Derek Miles again, he had an article many years ago titled "The Devil is in the Dosage." Just that's a good way to summarize exactly what you said. Is it may not be the thing that you're doing. It's just the amount or some other kind of variable that you can tweak to make this better for someone. That reminds me of a patient I had, I think it was last year, where she had this knee pain for like a year. She's been working with a personal trainer, doing all sorts of really cool stuff like back squats, lunges, you name it. But she just kept having this knee pain. And they were doing more of like a traditional strength plan. So probably like 5s, 8s, not really anything above 10 reps, generally pretty high intensity. So like 70, 80% of her 1RM. And I was like, okay, like I think your knee pain isn't due to damage. I think we just need to change the way you're going about things to get your body a little bit of a different experience. And I bet your knee's going to feel better in the next like month or two as we go about these changes. So what I recommended and did with her in the clinic was I just changed her intensity and I changed her volume, her sets and reps, but I kept the movements the same. And after like 3 weeks, her knee pain was gone. And I didn't expect this, but she was kind of upset with me. She was like, I don't really know why I'm seeing you. I'm doing all the same movements that I'm doing with my trainer. Like, why don't I just do them with my trainer? And we're people too. I'm not like some saint all the time. I do have feelings. But I was like in my head, you had pain for a year doing this stuff with your trainer. All I did was I changed some of the numbers around them and you felt a lot better. Like, did you want to keep having knee pain? Because it wasn't really working with your trainer anyways. I know that what I did seems simple, and not frankly, I think it is, but you don't have knee pain anymore. That's a great thing.
Right.
And more importantly, and this is what I really said to her, was like, yeah, totally. Like, I get what you're saying. And that was mainly, I think you should take this mainly as proof that what you're doing is great. Just sometimes you need to add some more variety in how you're going about it. And now that you recognize that, you have those skills to do that with your trainer moving forward. And now you know how to get out of knee pain, at least this type of knee pain.
Right. Yeah. No, I love that story. And I think it kind of just encapsulates kind of what we were talking about with this article, just in a different part of the body, And sometimes the best answer is really simple. And it can be kind of frustrating sometimes for individuals, because it's like, why am I coming here? You just changed numbers. Like what the heck is that about? But like you said though, sometimes the best way of treating someone in this context is just simplicity.
Yeah, doesn't have to be as flashy as YouTube might make it out to be. Bottom line is, are you getting better? And that's all that really seems to matter to people really in the long run.
Yep, absolutely, man. Yeah. Well, anyways, I kind of gave my closing thoughts. As long as I'm thinking that was maybe your closing thoughts, unless you have anything else, but I think we did a pretty good job of just kind of reviewing this article and hopefully putting in it more layman's terms for individuals to take some advice from the podcast and help themselves or someone they know out.
Yeah, absolutely. I think I'm good with my thoughts.
Perfect. All right, Christian. Well, thanks so much, man. I appreciate it. And we'll be back next week with, I don't know, some other kind of podcast. We'll figure it out. But all right, dude, we'll see you later.
See ya.